Radiographic Evaluation in Clinical Scenarios webinar. It is a privilege for me to welcome our speakers in this webinar. All of them are distinguished cardiologists, experts in cardiovascular imaging. Cardio Academic thanks Dr. Manivannan, Muhammad Sadiq, and Leonardo Rodriguez for accepting to give us such interesting talks. Also, it is my pleasure to introduce Dr. Daniel Piñeiro, who will collaborate with me in the coordination of this webinar. Dr. Piñeiro is a prominent representative of Latin American and world cardiology. He is professor of medicine at the University of Buenos Aires, Argentina, Board of Trustees of the American College of Cardiology, Roadmaps Liaison Officer in the Science Committee of World Heart Federation, past president of the Argentinian Society of Cardiology, and past president of the Inter-American Society of Cardiology. Welcome, Dr. Daniel Piñeiro. It is a honor to introduce Dr. Manivannan. He's an outstanding cardiologist and researcher in echocardiography, well known to all of us because he has participated in several conferences in our country, and he is co-director of the Cardio Academic. Today, Dr. Manivannan will talk about the role of multimodality imaging in mitral regurgitation. Welcome, Dr. Manivannan.
Thank you. Thank you for having me. And thank you, Eric Aloha, for inviting me to this webinar. Nelda, Daniel, hello. I will take a little bit of your time this evening to talk to you about multimodality imaging in mitral regurgitation. My conflict of interest for this presentation is shown on this slide. I get speakers honorarium and research support from Siemens. When we say multimodality imaging of mitral regurgitation, we really mean two modalities, echocardiography and cardiovascular magnetic resonance imaging, or we'll just call it MRI for the rest of the presentation. CT has a role, but mainly to define the mitral valve anatomy in planning interventional therapies. In terms of quantification of mitral regurgitation, when we say multimodality, much of the semi-quantitative and quantitative parameters is actually obtained by one of these two techniques, or both of these techniques. Vena contracta, semi-quantitative, PISA EROA, quantitative, and perhaps regurgitant volume and regurgitant fraction by 2D echocardiography, which is not done routinely. In MRI, the basis for using MRI to quantify mitral regurgitation is centered around measurement of regurgitant volume and regurgitant fraction. There is a possibility to get anatomic regurgitant orifice area by planimetry of the cross-section of the mitral valve by MRI also, although this is not done routinely. The best summary for looking at how we should look at multimodality, and as you will see throughout this presentation, in 2020, I think the term multimodality is passé. It is not really contemporary, nor it has any meaning. We should be focusing away from modality, but rather getting at what questions need to be answered. The best summary is provided in this table in the latest ASC recommendations for quantification of mitral regurgitation. This is a 2017 recommendations. As you can see here, outlined in the red box, vena contracta, regurgitant orifice area. When you do it by color Doppler, it becomes effective regurgitant orifice area, but some regurgitant orifice area. If this was MRI, this would be anatomic regurgitant orifice area. And then regurgitant volume and regurgitant fraction. Among all of these, Vena contracta is very specific to echocardiography. Vena contracta is not an MRI index. Effective regurgitant orifice area based on PISA is again specific to echocardiography, not really based in MRI, although MRI, as I mentioned, can get anatomic orifice area. The common parameter potentially between the two modalities is regurgitant volume and regurgitant fraction. And this applies to us on a daily basis when we look at patients with mitral regurgitation. In the same 2017 guidelines, the ASE guidelines, there is a fairly detailed discussion on the role of MRI. So as you can see, there is an increasing recognition that dividing things based on modalities is becoming irrelevant, if not already irrelevant. There is strengths in MRI, and there is certainly limitations in MRI. It is not a foolproof technique. One of the limitations mentioned in the 2017 guidelines with respect to MRI is that even though we will be able to measure regurgitant volume and regurgitant fraction, which I believe is the most physiologic measurement in any regurgitant lesion, MRI-based regurgitant volume and regurgitant fraction does not have well-defined cutoffs for severity grading, and there is limited outcome data based on MRI regurgitant volume and fraction, unlike PISA EROA. However, I must say this last statement in this 2017 guideline may be somewhat dated because since 2017, there has been a reasonable amount of data based on MRI regurgitant volume and regurgitant fraction in both primary and secondary MR, showing both prediction of therapy outcomes and also clinical outcomes. So this statement also may not apply in the future with regard to MRI. How do we get that regurgitant volume and regurgitant fraction? To me, this is the one thing that we do not do very well or pay attention to. By 2D echocardiography, as this cartoon shows, one has to make multiple measurements. You have to measure mitral stroke volume, and in a separate cardiac cycle, you have to measure the aortic stroke volume, and the difference of the two gives you the regurgitant volume. And clearly, this method also does not work or apply when there is significant aortic regurgitation. The problem with using 2D echocardiography is that it is time consuming. There are multiple measurements involved, and small errors can lead to very big differences. And in essence, in daily clinical practice, this number becomes extremely unreliable for routine use. And this is actually recognized in the 2017 guidelines without saying it in so many words. And that is why when they talk about regurgitant volume and regurgitant flow, they talk about using 3D colored flow Doppler as a way forwards rather than using 2D regurgitant volume and regurgitant fraction. With this in mind, now let's look at a case as how we can bring all of these indices, or what is the role. Do we need regurgitant volume and regurgitant fraction in everybody? The answer is clearly no. Mild MR is mild MR, whichever way, whichever index you use. Severe MR is severe MR, and the only reason to get regurgitant volume and regurgitant fraction in a severe MR, it would be to look at pre and post therapy, where the intervention makes it impossible to use PISA or routine vena contracta for looking at change based on therapy. Other than that, the most important application of quantifying mitral regurgitation is in the middle when there is moderate mitral regurgitation. Let's look at this case. This is a 76-year-old woman who has a history of quote unquote moderate MR. We see these kind of patients all the time. I'm sure many of you see these kind of patients. She has gone to a few hospitals. She was told in 2015 she has moderate to severe MR. In 2017, she was told she has moderate MR. She's completely asymptomatic, but worried that she is being told her valve lesion is either moderate or even maybe moderate to severe or severe. And then some of them have recommended intervention, even though she's completely asymptomatic. So she comes to us for assessment of MR for a third opinion. These are her transthoracic selected pictures, 4-chamber, 2-chamber, and apical long axis, color Doppler. And you can clearly see there is a mitral regurgitant jet. It is barely seen on the 4-chamber view. It is a little better seen on the 2-chamber, and it is again seen in the off-axis apical long axis view, not in your classical apical long axis view. But clearly there is mitral regurgitation, and visually it's very hard to tell the degree of mitral regurgitation. This is parasternal long axis view showing mitral regurgitation, very eccentric jet. And actually a PISA that you don't generally see this well in parasternal long axis. And in the short axis, which is very useful in 2D, you see a very medial jet. Again, in this particular short axis view, it looks pretty significant, although the apical views did not show that the MR was that significant, at least visually. This is B mode transthoracic, 2-chamber view. There is a hint of a prolapse in the posteromedial scallop of the posterior leaflet. This is either an A3 prolapse or a medial commissural prolapse. And again, in the parasternal long axis view, there is just a hint on the B mode. And that is why one was able to see that very eccentric MR in the parasternal long axis view with a prominent PISA. Clearly, there is an anatomic abnormality, which is a little unusual. This was a TEE done during one of her evaluations, which was done in her outside hospital. And in this TEE, clearly, there is significant medial mitral regurgitation. This is P3, P2, P1, medial, lateral. There is a very medial jet. Again, this is either an A3 prolapse or a medial commissural prolapse. And the vena contracta measured here was 0.7 centimeters. So, suggestion that this MR is a significant MR. These are additional views by that transesophageal echo, again showing a very medial jet and a posteriorly directed jet. So this lady seems to have a complex anatomy as the basis of her MR, perhaps A3 or a medial commissural prolapse. She's completely asymptomatic, and the question here is, how severe is this MR? This is 2D transthoracic echo. 2-chamber view was the best view where you could see the PISA, not the conventional view in which you would measure PISA, but being a very eccentric jet and a medial commissural prolapse, this afforded the best view of the flow convergence. The PISA radius was over 1 centimeters, and the PISA EROA based on this view was 0.43 centimeters squared, consistent with severe mitral regurgitation. Parasternal long axis view, again, not a conventional view on which you would do a PISA EROA, but the anatomy here and the eccentric jet allows us to do that. And the calculated EROA in this case is 0.20 centimeters square, let us say, consistent with mild or mild to moderate MR. So the question based on PISA EROA here is it mild to moderate or is it severe? There is no suggestion of moderate MR here, at least based on this limited examination by transthoracic echo. 2D vena contracta is 0.7 centimeters. Again, as the TEE showed, that confirms, that leaves us somewhere in the severe range, call it moderate to severe or severe. Mitral inflow pattern, not a E dominant flow. If anything, it's slightly A dominant flow, consistent with not severe MR. Then when we look at the right upper pulmonary vein flow, there is a very substantial systolic flow. Admittedly, this is only one vein, and you can argue with an eccentric jet, perhaps there is reversal in the other veins. In the previous TEE in the outside hospital that she had, she did have examination of other pulmonary veins, and this was the worst, and that was blunting at the most, systolic blunting. That would be, at least based on the definition, consistent with moderate MR. Spectral Doppler of the MR jet, if you compare it to the antegrade flow, it doesn't look as dense as that. So you could call this moderate MR based on density, extremely qualitative, but very useful. TR peak velocity was only about 2.7 meters per second. So maybe a mild increase in RVSP, but really no pulmonary hypertension. LV function was normal, LV size was normal, volumes were normal, and systolic dimension was normal. So if we go back to the ASC guidelines and quantification, or an integrated approach, if you will, this table shows the dilemma. The MR is anywhere between severe to mild to moderate. And she has a very complex anatomy on the basis, as a basis for this MR, whatever the degree of MR. So this leaves us with what to do next, because she's here, remember, to get some kind of definitive answer on the question of mitral regurgitation. She's asymptomatic, and she wants an expert opinion. So what are our options? One option is exercise echo. If we put her on an exercise and she gets symptomatic and the MR gets worse, PA pressures go up or RVSP goes up, perhaps we can make the argument that there is something to do here. Another option would be to look for regurgitant volume and regurgitant fraction, which we really haven't done here. And to do it by 2D TTE would be one option, but that is not an option that is easy to do, nor is it reliable. If you only do it once in a while, if you're going to do this, you ought to be doing it almost every day, at least in a few patients, so that you're good at it, and more importantly, you believe the numbers. One of the approaches, not clearly available to everybody, nor is it validated extensively yet, is the use of 3D volume color Doppler, where you can compute mitral stroke volume and aortic stroke volume by using the volumetric color Doppler across the mitral valve and the aortic valve. One of the advantages here is, of course, that you're doing it in the same cardiac cycle. The same color Doppler acquisition can be also used to characterize the 3D PISA surface area and get a 3D PISA EROA for what it is worth. But remember, 3D PISA EROA, although better than 2D PISA EROA, is not perfect. It also suffers from shortcomings, but it is slightly better. As you can see in this patient, even if you were to do 3D PISA, the 3D PISA surface varies throughout the systolic phase of the cardiac cycle. It is flat here, it is round here. We see this in 2D echo, but we take the largest PISA and measure the largest PISA. The best way here would be to integrate the regurgitant volume throughout systole from PISA and get a regurgitant volume, because it happens to be the most physiological indicator of the amount of blood leaking back into the left atrium. But in this particular case, because PISA is both flat and round, we did not rely on 3D PISA. You could choose any one of them and you would get two different answers. And therefore, according to this one measurement, one would suggest that 3D PISA EROA 0.32 would actually put it in the category of mild MR. So remember, 3D PISA EROA is slightly better, and it's always bigger than 2D PISA EROA, but it is not always possible to do it, and still it's a single frame technique at the present time. You choose the largest 3D PISA and you do the surface area of that, and then you derive your 3D PISA EROA. It does not really integrate what happens throughout systole. So using the same data set, one can compute the mitral stroke volume and the aortic stroke volume. And this is how we do it. Again, I understand that this technology is not available yet widely, nor is it extensively validated. But in our lab, where we've used this for a while now, at least a few years, we do rely on this number as long as the data quality is good. Here is how this patient numbers look like. We do 3 beats. This is 1 beat, 2 beat, 3 beats. And we compute the inflow stroke volume and the outflow stroke volume in beat number 1, beat number 2, and beat number 3. And then you also get the average of the 3 stroke volumes, inflow stroke volume and outflow stroke volume. The difference of that gives you the regurgitant volume, and regurgitant fraction is nothing but regurgitant volume divided by the inflow stroke volume, right? That is your total stroke volume, the MRI total stroke volume. So in this case, as you can see, the numbers are similar in beat number 2 and beat number 3. In beat number 1, the inflow stroke volume, which we use as our index of reliability because it is most parallel to the ultrasound beam, is much lower than beat 2 and beat 3. So we would consider this to be an outlier. We would leave that out for the reasons that I just outlined and take the average of beat 2 and beat 3, and we get a mitral stroke volume of 89, aortic stroke volume of 52, regurgitant volume of 37, let us say, and regurgitant fraction of 41%, all consistent with moderate mitral regurgitation. So this particular index in the guidelines, regurgitant volume and regurgitant fraction, which is done in a small minority of patients on a daily basis, is actually very valuable in instances like this. Whether it is done by MRI or by echo, this is an important parameter that we miss on a daily basis. So based on this, now this puts it in the moderate category, and on the whole, we felt that this was moderate mitral regurgitation. The patient had MRI because that is the conventional way to do regurgitant volume and regurgitant fraction. Regurgitant volume is 41 mils. By 3D echo, it was 37 mils. Regurgitant fraction is 39%. We got 41% or 42%. Moderate mitral regurgitation. This number here, when done well, is perhaps, in my book, the tiebreaker, irrespective of whether it is done by echocardiography, even 2D, except it ought to be done well. And of course, if you have aortic regurg, you cannot do it. This is the number that breaks the tie in this particular patient. And to me, it's a very important index. We felt this was moderate MR based on preponderance of evidence, and we decided no intervention at this time. So when should we look at regurgitant volume and fraction? It is very useful in primary MR when PISA EROA is unreliable, when there are multiple jets, and especially when you have an abnormal LV size or function out of proportion to what integrated approach by echo says as moderate MR. There, getting a regurgitant volume fraction is key. In secondary MR, it's almost always useful because except for mild secondary MR, PISA EROA either wildly underestimates or overestimates moderate mitral regurgitation. So I think regurgitant volume and regurgitant fraction is something that we ought to integrate in our practice. And if we look at it that way, we don't really care whether it's MRI or is it 3D echo color Doppler. For the sake of time, I'll bypass this case too, except to make the point. This is a post-mitral clip. In post-mitral clip, PISA and vena contracta are extremely unreliable, whereas regurgitant volume, if you need to look at residual MR, is one way to do it by color Doppler or by MRI. MRI has some challenges, but it is a very good index to follow patients with residual MR post-clip if you need to evaluate the amount of residual MR. And this is an example where MRI and echo were agreed, both the techniques agreed on the degree of MR. In essence, the arguments we continue to have sometimes about modalities is irrelevant in this age where everything is focused on therapy. There is very little time to be arguing about the degree of the lesion. Instead, we should be arguing about or having a discussion about what is the best therapy in the patient. And we should not be worried about what we want, but more focused on what we need and the central question. And the central question is, what information do we need to intervene in timely and successful fashion? Out of many, there's only one concern, and that concern is reliable information that helps us to make good decisions. That is the most important question. I think multimodality is better termed as integrated imaging rather than multimodality imaging. And that is the phrase that makes sense to me in the current era, not multimodality. Muchas gracias.
Thank you, Dr. Manivanan.
Okay, Nilda, could you introduce the second speaker?
Yes, please.
Okay, first of all, thank you, Dr. Eric Alexanderson, Marco Antonio González Tejada, and it's my pleasure to share this coordination with Dr. Nilda Spinola. Now, the second talk will be given by Dr. Mohamed Sadiq. He is the director of echocardiography, and he is professor of medicine at the New York University Langone Medical Center in New York City. Thank you for sharing to be here, Dr. Sadiq. Dr. Sadiq will address essential role of multimodalities imaging in and guidance of percutaneous mitral valve repair and replacement. Thank you for joining us, Mohamed.
Daniel, thank you so much, and Nilda for your invitation. It's an absolute pleasure with greetings from New York City. And I'll try to talk about the rol esencial de la imagen multimodal en la reparación mitral, quirúrgica y percutánea. I hope it's Spanish good enough. So you can see my screen?
Yes.
Yes, you can see my presentation? Okay, so these are my disclosures for this presentation. And let's look at an overview of mitral valve interventions. So when we talk about mitral valve intervention, we really have to know very well the mitral valve anatomy in a particular patient. And that primarily involves in echocardiography, 3D imaging of the mitral valve. And then we have to know what the normal valve looks like and what are the normal variants before we start talking about abnormalities. And with respect to mitral valve intervention, we can divide them into two groups, with the mitral regurgitation intervention, and probably most common is the percutaneous edge-to-edge repair. Then there is the transcatheter mitral valve annuloplasty, and then transcatheter mitral valve replacement. And this, I mean transcatheter mitral replacement of a native valve, which is separate from a surgical replacement of a surgical mitral valve in valve after a failure. And then also with mitral regurgitation, percutaneously, we can do prosthetic paravalvular leak closure. On the mitral stenosis side, we can talk about the percutaneous mitral balloon valvuloplasty, as well as interventions for mitral annular calcification associated mitral stenosis, probably the most challenging form of mitral valve disease. Let's start a little bit of a 3D echocardiography of the mitral valve, and it's truly the essential role that 3D echocardiography plays in characterizing the mitral valve pathology, as well as the guiding percutaneous procedures. So clearly 3D imaging of the mitral valve is not something new. We have been doing this since the 1990s, originally with the standard 2TE probe. And just as a reminder, standard TE probe has about 64 to 128 imaging elements. And actually with the appropriate software, you can acquire sequential 2D imaging, and you can acquire 61 clips every 3 degrees, EKG gated. And you can then use a powerful computer to extract these images, and after an hour or a couple of hours, you will get the images that we got in the 1990s. So this is one of the images that I got in 1998 or 1999 showing a normal mitral valve. So clearly we have been able to do that, but not in a real time. So this is one example of the 1990s. We could show the anterior leaflet, we can show the posterior leaflet, medial and lateral commissure, but at that time we still didn't know how to orient the mitral valve in what we know now as the surgical view of the mitral valve. So, and this is a normal mitral valve in a moving image. At that time, we could even tell there is, for instance, a P2 prolapse of the mitral valve, and then even a severe mitral stenosis on the left atrial side. But this is 1990s. What about the real time? So real-time echocardiography really came in the 2000s, and essentially it's a fundamental change that instead of a 64, 128 imaging elements, 3D TEE probe has a 3,000 imaging elements, and that allows for simultaneous acquisition of many 2D images and a real-time 3D volume set. You just press a button and you get the 3D image. And that's the fundamentally change, because if it's not real time, it cannot be guided for the procedure. And this is a normal valve, a normal mitral valve. And even at that early stage, we had to decide how to display the mitral valve. And this is, we decided all over as a community to display the valve in the so-called surgical view. But the aortic valve is on the top, left atrial appendage on the left, and interatrial septum on the right. And these are the posterior leaflet segments, P1, P2, P3, and I also labeled one of the anterior leaflet segments, which is the A2. And then if you need to be able to correlate the 3D views to the standard 2D views, so the LVOT view about 135 degrees will be through the aortic valve A2 and P2, as opposed to the commissural view, which is anywhere between 45 and 60 degrees, will go P3, A2, and P1. And this then allow us to talk about the lateral and medial and anterior posterior orientation of the mitral valve. And here I also showed all the intermediate angles from 0 to 90, 130 degrees that you can correlate the 3D to existing 2D views. However, it's extremely important that this so-called surgical view of the mitral valve is not the anatomic view. It's an artificial view. It's the view that the surgeon sees the mitral valve because she or he rotates the patient 30 to 60 degrees away from herself to show the mitral valve. But anatomically, this is the orientation of the mitral valve. Essentially, you can see the left atrial appendage is on the top of the image, coronary sinuses on the bottom, and you know P1, P2, and P3. And from experience, we know if we see the aortic valve, if we are very cranial with the probe, we see P1. If we advance the probe a little bit deeper, we will end up with the P2 and A2. And if we go even further into esophagus, we will have a P3, A3 at the level of the coronary sinus. So it's extremely important to differentiate the surgical from the anatomic view of the mitral valve on 3D imaging. So this would be a cranial. This is A2, P2 with the true 4-chamber view. And if we have a deep transesophageal view, we will see A3 and P3. And now if I were to show you in one clip, all the interventions that we typically do at an institution would be like this. So this is percutaneous mitral intervention. We'll start with a single mitral clip. That is a really clip in the middle of the valve. And a percutaneous edge-to-edge repair, and a mitral clip is the one that it's first came. We can have a one clip, or this is intervention with the 2 clips. And then we can have a transapical mitral valve replacement. This is Intrepid from Medtronic. This is a native valve that it's replaced with the bioprosthesis. Or we can have a transeptal placement of a native valve, which is one of the caisson valves, and it's a fully deployed. And finally, we can have a mitral valve in valve, which is a procedure in which the failed bioprosthesis is replaced with the transcutaneous transcatheter valve, which is a TAVI valve repurposed for a mitral position. So now let's look at the one by one. And if this were a live audience, I would ask the audience to choose whether they would like to have mitral clip or standard edge-to-edge repair, or maybe Pascal with the mitral clip alternative. We can discuss transcatheter mitral valve replacement or TMVR of a native valve, PVL closure, or intervention for surgical valves and repair, such as valve in ring, or valve in MAC or mitral annular calcification. So maybe I should choose, many of you have seen a lot of presentation of mitral clip, which is a standard procedure, but I'll tell you maybe an alternative, which you may not have seen. So it will be a Pascal procedure, or Pascal and a clasp trial, which is a mitral clip alternative. So alternative to mitral clip edge-to-edge repair, and we can start with the question, are there any alternatives, percutaneous alternative to mitral clip edge-to-edge repair? And clearly there is, and one of such alternative is being developed by the Edwards-Pascal system, and the clasp, the other name is the clasp system. Essentially Pascal is the trial that the system is being evaluated. And this is how this Edwards-Pascal transcatheter valve repair system looks like. It's similar to Abbott's mitral clip, and these are the parts of this. There's a spacer, there's a clasp and pedals, and if you compare this to mitral clip, clip arms and grippers are equivalent to pedals and clasps. So let's try to see how this is implanted in a native valve. So this is essentially just a system to independently have clips positioned in the mitral valve, and then these are the different orientation of the clip, the implant elongation that you introduce this, then you put it together, and then you orient it at the level of the mitral valve. So let me show you in a couple of these. So there is a transeptal puncture, just as a mitral clip. You advance the guide catheter and the wire, and then you replace you remove the wire and the dilator into the guide catheter, and then through the guide catheter, you advance the Pascal system. And you see that it's in a long system, so it be allowed to go through the relatively narrow catheter. And in the next step, the system is folded in a stepwise fashion until we get a completely folded system. You see now it's wider than the catheter itself, and that's the point of having it elongated at the beginning, and now we can fold it into implantation ready assembly. So now we will advance this folded catheter toward the mitral valve, and then we can open the clasps or the paddles, and then we will advance it in the open position through the native mitral valve, and then grasp the leaflets that would be flail or prolapsed, or the functional mitral regurgitation that are just separated from each other. And then we can close the device, and individually we can use one or the other clasp. And I can see this, how it's being done. And we then close it just as we would do with the mitral clip. And if we are satisfied with this position, we will then release the Pascal system. And then you will actually see just any edge-to-edge repair. In this case, that was done A2P2. And a slight difference from the mitral clip from Abbott is that this system, Pascal system, had a spacer between the two arms of the clip. And then let's look at how we can do this procedurally on a TE, how we can guide. So this is the unfast view of the mitral valve, and it's on the bottom. Mitral valve is on the bottom, and we have interarterial septum, and you see that there is the guide catheter has already crossed the interarterial septum, and the guide wire is in the left upper pulmonary vein. So wire in the left atrium, and the next we'll have the whole assembly. See that we advance the clip, and then we are pulling it back into the folded position to be ready to be advanced toward the mitral valve. That's a Pascal assembly in the left atrium. So now we see that we have assembled in the folded clip. We will now move it toward the mitral valve. Pascal positioning in the left atrium. And then now we have actually moved it toward the mitral valve. We have oriented, we are now unfast, and in this case, it's at the level of A2 and P2. And we will open we have opened the clasps and then the paddles. So we are orienting it perpendicular to the coaptation line, clasp orientation in the left atrium. And the next, we will advance it into the ventricle and grasp the leaflet, just like we would do it in the other form of percutaneous edge-to-edge repair. And you see we have grasped A2 and P2 in this orientation. So we grasped, and the next we will then check whether for the satisfaction, how satisfactory the result is. And essentially you can see that this is an excellent result. Severe mitral regurgitation became trivial after this procedure at the A2, P2 level. And then this is now released system. and it looks like just a mitral clip, except that there's a spacer in between the two leaflets. So the Pascal is released, and we are satisfied. So this will be a Pascal, and this was the mitral clip. So essentially the same procedure, A2P2 level, and the only difference is there is a slight spacer between the two arms of the clip. And then it's a 3D color. You see there is a really trivial degree of mitral regurgitation, confirming this is a very successful edge-to-edge percutaneous repair of severe mitral regurgitation. And then we can also combine, you see that the mean pressure gradient is only 1.4 millimeters, so therefore we did not induce iatrogenic mitral stenosis. So this would be an alternative to mitral clip. And something we knew. Maybe how about if we discuss also transcatheter mitral valve replacement? This is another, and I'll show you two different approaches. One is the Caisson transcatheter mitral valve. This is a transvenous transplant implantation. And this was at that time the only transvenous transeptal form of a native mitral valve replacement. And at NYU in 2016, we were first in the world to do this procedure. And we presented these results in 2016 TCT meeting in Washington, DC. And this is a Caisson valve system. And this is the team that we were implanted and led by Matt Williams, who is the director of a heart valve center. And let me just show you what this conceptually, the system has since been, the development has been stopped, but similar system will be developed in the future. So essentially has an anchor into the native annulus, because remember, mitral valve disease is not calcific disease for the most part, as opposed to aortic valve stenosis, which is for the most part calcific, and therefore we can use the calcium to anchor the percutaneous valve. Here we have to have a separate anchor, and then we can put the valve inside to have a valve in anchor system. And then this is how the assembly looks like in real life, both the valve and the anchor. And so this is a cartoon of the procedure. We do the transeptal as we do it in any other. There is a guide catheter, then we put the wire across, through the catheter, and then this is, we will open up the anchor. And the anchor has 4 feet, 2 anterior and 2 posterior feet. We will then advance these 4 feet into the left ventricle and anchor them on the ventricular side in something what we call the mitral gutter. So you see, now we will advance it into the ventricular position, and now we are looking from the ventricular side how these feet, this is here the posterior foot and the other one is anterior foot, and see they're anchoring at the ventricular side in the gutter of the mitral valve. And then we ascertain that everything's okay, and after we do that, then we open up the atrial retention features, these 3 loops on the atrial side that then sandwich the native annulus between the feet and these retention features. And after we are satisfied, then we will place the actual valve, prosthetic valve, which is similar to any bioprosthetic valve, a tri-leaflet valve, and we'll put in the position and see if we can do this successfully. And you see we are now opening the valve inside the anchor, and then in the next step, if everything goes okay, the valve will be functioning and the mitral regurgitation will be resolved. So let's look at how this in real life. So this is somebody with the large P2 flail. The patient refused the mitral edge-to-edge repair and preferred to have a permanent solution with the percutaneous valve. Here we will actually see that on a 3D, on an unfast view, how we introduce the folded anchor into the left atrium. And then you will see how we now oriented the anchor. See that there is an anterior foot, and there are 2 posterior feet. The other anterior foot is covered by the delivery sheath. And then the next level will open after we anchor the anchor on the ventricular side in the gutter, that we open 3 atrial retention feature to fix the anchor in place. And once we are satisfied with this, we will then put the prosthesis and to complete the procedure. And now you can actually And this is, unfortunately, this form is halted the development, but I'm sure that somebody will come up with a similar approach. So another approach is an intrepid transcatheter mitral valve, which is the transapical, although the company is developing a transseptal transvenous approach. And this is a Medtronic intrepid transcatheter mitral valve system. This is the actual system, which incorporates the anchor and the prosthesis into one unit. So there is a brim of the anchor, there is an outer stance, which is the anchor, and an inner stent, which is a 27mm bovine mitral prosthesis. And this is a video of that valve, how it looks like in real life. And then I can actually show, I think there is one part that we cut it in half, and you actually see how the anchor moves separately from the prosthesis itself. And then what do? We do transapical. This is a surgical approach. The surgeon has to open up the chest and expose the cardiac apex. So we advance the capsule, which contains the prosthesis, through the transapical approach and advance it into the left atrium. We then partly open the prosthesis with this brim, this is outer, and advance the brim toward the mitral valve. And then when we are satisfied, we fully inflate the prosthesis, and there are little anchors on the outside of the outer brim that catch the native leaflets and the annulus to anchor in place. And this is the left atrium, left ventricle. And then this is the next step, how we open the valve partly and then finally deploy. And this is just a little animation, how we do that. See, there is a capsule and we advance toward the mitral valve. If we are satisfied, we'll then fully employ it, and these barbs that catch the annulus and the native leaflet. And then we will deploy the valve in a functioning manner. So this is, let's look at how we do that. We start first, as this is multimodality imaging, we'll proceed with the CT planning, and then we'll decide what the native valve size is, how much is the neo-LVOT might be after we implant this prosthesis, and then what's the location of transapical access. So this is how we do that, how we determine the size of the native valve and what size of the prosthetic valve we are going to put. And then there is an oversizing like any other valve that we place. And then we can also measure the neo-LVOT, which can predict what the size, and we want the neo-LVOT cross-sectional area to be larger than 1.5 centimeters squared. In this patient was 3.5 centimeters squared, which is more than sufficient. And then we can actually also predict where to do the transapical puncture and this apical access site. And we can really guide the whole procedure and see this is the best orientation within the fifth intercostal space. And then this is the video, shows that the surgeon exposed the apex. So this is really still a surgical procedure. And then in the next step, we will actually show that then the surgeon pokes the apex, and we have to show that on imaging that this apical poke, ascertaining that the surgeon is truly at the true apex and to perform the puncture there. So this is a transapical, this is apical poke. And then in the next step, after we are satisfied, we will advance the capsule into the left ventricle, just as you saw it in that animation, and then through the mitral valve into the left atrium. So this is commissural view and LVOT, which are two key views in any mitral valve procedure. So that's the capsule in the left ventricle, and then we can see it on fluoroscopy as well. In the next step, we will advance the whole system into the left atrium, open the brim, and then bring the partly open prosthesis toward the native annulus. Commissural view, LVOT view, TEE, and then fluoroscopy. And that's really opening of the brim. And then now, if we are satisfied, we will then bring the whole system down toward the native annulus and the leaflet, and then fully deploy the prosthesis. Commissural view, LVOT, two key views for the procedure, and then we will see it on fluoroscopy. This is fully deployed. That's the brim, outer ring, and an inner ring, and inner ring represents the prosthesis itself. And this is how it's being deployed. So it's a fully functioning mitral valve, completely resolving the prior severe degenerative mitral regurgitation. That's the outer ring, that's the inner ring, and And now you see there is no paravalvular regurgitation. There is a trace transvalvular regurgitation, telling us this is an excellent success. And now we can actually see that from the ANFAS view, this is a inner ring, outer ring with the brim, and it's a fully functioning prosthesis. So how am I doing with the time? It's good, 20 minutes. Is that okay, Danielle?
It's okay. We are a little delay, but it's okay. Thank you.
So I'll thank you very much, and muchas gracias.
Let me thank you for your very excellent presentation, Mohammed. And this I'm going to the next speaker, who is my privilege and a special privilege for me to introduce you, Dr. Leonardo Rodriguez. Leonardo Rodriguez is a very close and very dear friend of mine, and I know him for the last, I think, 20 years. Let me say that Leonardo is working in Cleveland for many years, but most important, okay, we have time. We have 15 minutes more. So I want to remind you and let you know that Leonardo is very, very important in the history of percutaneous technology. Leonardo, very, very young Leonardo, in 2003 was part of a team led by Jose Antonio Condado, who performed the first percutaneous edge-to-edge mitral valve repair in Caracas, Venezuela. So for me, it's a very, very pleasure to introduce you, Leonardo Rodriguez, who is going to address today multimodal evaluation of the aortic valve and transcatheter aortic valve replacement. Thank you, Leonardo, to be with us.
Gracias. I want to apologize to Dr. Sarik because I'm going to switch to Spanish for the rest of the talk.
Oh, yeah. Are you going to talk in Spanish?
Yeah.
Bueno, creo que la audiencia es fundamentalmente hispana, así que primero quiero agradecerlo a ustedes por la invitación.
Entonces te voy a mandar un abrazo en español.
Muchas gracias por tu introducción. Y es verdad, cuando era joven, hace muchos años, tuve el privilegio de participar en este procedimiento que ahora tiene miles o decenas de miles de válvulas reparadas con esto. Vamos a cambiar de válvula ahora de la mitral a la otra, ¿no?
Ok, te quiero comentar que tengo una fotografía muy linda donde está todo el grupo y vos estás ahí y te preservás joven como en aquel entonces. Un abrazo. Gracias por
un abrazo. Pesaba 20 kilos menos, sin embargo, pero bueno. Tengo unos pocos minutos, vamos a tratar de cubrir este tópico que es bastante importante.
Leonardo, me informan que tenemos una extensión del tiempo, así que tómate tus 20 minutos con tranquilidad.
Bueno, perfecto, muchas gracias.
Para las preguntas, ¿ya?
Sí, esperemos que esto funcione aquí.
Y un poquito más de tiempo.
Gracias. Al parecer, como que soy el único que no tiene nada que decir de sus conflictos de interés, realmente no doy charlas pagas. Por cierto, Daniel, esta me la debes, que te la voy a hacer a crédito, ¿ok? Bueno, no quiero realmente decirles la importancia de este tema y me van a perdonar algunos errores aquí en la traducción porque algunas de las diapositivas estaban en inglés. Así que este es un poquitico de Spanglish en las diapositivas y les pido que me disculpen. Pero realmente los últimos años han sido muy provechosos para el tratamiento de la válvula aórtica y grandes estudios aleatorios han probado que esta es una técnica efectiva a largo y a mediano plazo y es una técnica que empezó con pacientes inoperables, luego pacientes de alto riesgo, pacientes de riesgo moderado y aún se ha probado que es efectiva en pacientes de bajo riesgo. Así que esta es una técnica que va a quedar y ha sido refinada y seguirá va a ser más refinada. Y realmente el éxito de esta técnica, además de mejorar los equipos y las válvulas, también se ha debido a que la imagenología cardiovascular ha crecido en forma paralela y le ha permitido entonces desarrollar, al igual que la charla anterior con la válvula mitral, estos procedimientos que son bastante avanzados. Ahora, inicialmente, cuando esta técnica comenzó, obviamente lo único que buscaban era si el paciente moría o no a 6 meses o 1 año. Las expectativas ahora que se utiliza en pacientes que tienen bajo riesgo han aumentado. Y lo que esperamos de estos procedimientos es que la mortalidad sea muy baja, inferior o igual a la mortalidad quirúrgica, que tenga una fuga paravalvular mínima, porque eso tiene valor pronóstico, que tenga una baja incidencia de marcapaso, y aún en esto se ha mejorado, y de 20% esto ahora se ha bajado a 10% o menos. En algunas instituciones como la nuestra, la incidencia de marcapaso es en el 1 o 2%, que no tenga ruptura del anillo aórtico, una emergencia muy severa, y que por supuesto no tengamos otras complicaciones como la obstrucción coronaria. Y para cada uno de estos papeles, la imagenología es claramente muy importante. Como decía el doctor Piñero, que yo soy un poco mayor ya y me ha tocado vivir realmente la historia de todos estos procedimientos. La historia de la evaluación de la válvula aórtica con múltiples modalidades obviamente tiene mucho tiempo. Sabemos hace muchos años que la válvula calcificada va a tener mayor severidad de la estenosis aórtica, y esto se vio fundamentalmente con fluoroscopia, que era una forma diagnóstica de esta patología. Luego, con los estudios de hemodinamia, donde la medición directa de presiones y flujo permitieron aplicar la fórmula de Gorlin y calcular el área valvular. Y luego, con la aparición de la ecocardiografía, que fue fundamentalmente dirigida a la válvula mitral, pero luego se extrapoló a la válvula aórtica, nos permitió ver ya en tiempo real la morfología de la válvula y también medir a través del efecto Doppler las velocidades y de ellos los gradientes, y calcular, combinando el eco con el estudio Doppler, el área valvular con la ecuación de continuidad, y esto permitió obviamente valorar la severidad y el manejo de estos pacientes. En la era actual, una vez que aparece este procedimiento percutáneo transcatéter, realmente el eco sigue siendo importante, pero necesita ahora unas imágenes adicionales, y en particular el uso de la tomografía computarizada, que nos permite ver mejor la anatomía valvular, el grado y distribución de la calcificación, el acceso de las coronarias y el acceso vascular y la visualización de las coronarias. Papel menor tiene la resonancia magnética en pacientes que no puede hacerse la tomografía computarizada o que el eco es muy mala calidad, para ver el anillo mitral, y en algunos casos para ver la función ventricular y la cantidad de fibrosis miocárdica que puede tener impacto en el pronóstico de estos pacientes. ¿Por qué entonces necesitamos otra metodología? El eco, sin duda alguna, sigue siendo el caballito de batalla y la primera modalidad para diagnosticar a estos pacientes. Tiene muchas ventajas que ustedes conocen. Es portátil, lo podemos llevar a cualquier parte del hospital. Nos permite ver la anatomía y función de la válvula. Es ideal también para ver otras válvulas asociadas, como la válvula mitral o la enfermedad tricuspidia. Y si a estos pacientes le hacemos eco transesofágico, podemos valorar todo esto mucho mejor. Sin embargo, tiene obviamente muchas limitaciones. Una, que es altamente dependiente de la persona que lo hace. Si el técnico o el médico que recoge estas imágenes no hace un trabajo completo y excelente, la visualización y la interpretación puede ser dudosa. La ventana acústica ya depende, y les pongo el ejemplo de Ohio, donde yo trabajo, donde la obesidad es bastante importante, y aún a pacientes que fuman. La combinación de obeso con enfermedad pulmonar hace que la ventana acústica sea muy limitada y tiene impacto de nuevo en la calidad. La relación señal-ruido es subóptima, y es algo intrínseco del uso de ultrasonido, y a veces de nuevo impide la captura de imágenes de gran calidad. Y la interpretación, que en muchos aspectos es solamente semi-cuantitativa, depende de la experiencia del observador. Y finalmente, en válvulas calcificadas, la sombra acústica que produce estas válvulas oscurece en muchos casos el área subaórtica y no permite ver el anillo bien. Ha habido una cantidad de artículos, este es solamente uno de ellos, esto ya tiene varios años, pero ya ven ustedes que ya ha habido uso y discusión de las múltiples modalidades, y obviamente hay ecocardiografistas, intervencionistas y de otras modalidades que han atacado este problema. El doctor Sarik también publicó esto hace unos 2 años, donde él habla del papel de las diferentes modalidades antes del procedimiento por eco y tomografía computarizada, durante el procedimiento que ahora es fundamentalmente fluoroscopia y muy poco la ecocardiografía, al menos en los centros donde se hacen estos procedimientos en gran volumen. Ahora rara vez se hace un eco transesofágico y se hace un eco transtorácico muy limitado, y obviamente después del procedimiento la ecocardiografía vuelve a ser parte de la parte primaria diagnóstica, aunque yo diría que también la tomografía en el seguimiento y con el diagnóstico de trombosis de las prótesis, la tomografía también se utiliza, no con rutina, pero sí con frecuencia en el seguimiento de estos pacientes. La anatomía de la raíz aórtica es extremadamente importante porque recuerden que es ahí donde se va a poner el aparato, la válvula prostésica que se va a sostener del calcio y del aparato subvalvular o del área subvalvular, y por lo tanto de gran importancia la medida precisa del tamaño. No solamente es el tamaño, sino también la extensión de la calcificación, y sabemos que calcificación que se extiende a la válvula mitral y que es muy extensa puede aumentar la incidencia de ruptura del anillo aórtico. Y es por eso que es tan importante hacer estas medidas. El tamaño de la válvula se escoge antes del procedimiento, en la mayor parte de los casos, basado en estas mediciones de los diámetros, áreas y perímetro, y permite entonces tener la válvula adecuada, y el intervencionista sabe muy bien de antemano qué tipo de procedimiento va a hacer. Este es un esquema de lo importante de esta área, no solamente el área del anillo, sino los diámetros de los senos valsalva y también del diámetro de la unión sinotubular. Cuando esto es muy bajo, algunas válvulas no pueden ser expandidas completamente si esta área es muy pequeña. Y luego, obviamente, la definición anatómica y de las válvulas y de nuevo del anillo aórtico. También ven ustedes la relación entre las valvas aórticas y las ostios de las coronarias, y usted puede imaginar que si ustedes expanden la válvula y elevan estas valvas, pueden obstruir una de las coronarias, y una complicación rara, pero conocida de este procedimiento. No quiero entrar en mucho detalle porque ustedes todos son expertos en esta área, pero la evaluación ecografía tiene que ser muy completa. Tienen que recoger todos los datos necesarios para el cálculo preciso de la ecuación de continuidad. Deben ustedes medir el anillo aórtico. Siempre se sigue asumiendo que es circular, aunque en muchos casos no lo es, y esto lleva a cierto error en el cálculo del área valvular, pero sigue siendo el procedimiento o la medida establecida para eso. Y si tenemos eco tridimensional, obviamente debería ser aplicado porque ofrece la posibilidad de ver el anillo no solamente en una dimensión, sino en varias dimensiones, y es de bastante utilidad en la mayoría de los casos. Este es un ejemplo donde pueden ver ustedes las limitaciones y las ventajas de la ecocardiografía. Pueden ver ustedes la función ventricular izquierda bien, pero ven ustedes que en este caso particular clásico del área donde trabajo, las vistas no son óptimas. Ven ustedes que la calcificación a nivel de la válvula aórtica del anillo hace que estos bordes no sean particularmente nítidos. Ven ustedes en el eje corto de la válvula aórtica que incluso la anatomía, si es bicúspide o tricúspide, no está claramente delimitada en este caso. Este es un caso similar, pero ahora con eco transesofágico. Ven ustedes aquí que se puede hacer la reconstrucción multiplanar, muy similar a lo que se hace en la tomografía computarizada. Aquí las vistas son mucho mejores, la resolución de la imagen es mucho mejor. Y ven ustedes aquí en el eje corto, donde pueden verse que también es un área subvalvular que no es completamente circular, y de nuevo también puede ser corroborado en la reconstrucción tridimensional. Ven ustedes aquí, es del mismo caso, en una imagen congelada, donde se puede ver lo que les mencionaba a ustedes de la sombra acústica del calcio. Ven ustedes estas flechas muestran las zonas calcificadas, donde son áreas de discontinuidad del ultrasonido y introduce un elemento de adivinar o de dónde está el contorno de esto, pero también es útil esta imagen para ver ustedes cómo ocurre donde el eje corto es, y el eje mayor de esta área pues son disimilares, lo que indica que esta es un área, un tracto de salida más o menos ovalado. De manera que si solamente medimos un diámetro para el cálculo introducimos un cierto error en la medida. Y esta es la forma, utilizando el eco tridimensional, donde se calculan estas medidas. Se hace un trazo manual y podemos medir los diámetros cortos y largos, y esto nos da el perímetro y el área. Y de nuevo, estas son las medidas que se utilizan para escoger el tamaño de la prótesis que debe usarse. Ha habido varios estudios, estos son estudios que ya tienen algunos años, pero el mensaje sigue siendo más o menos el mismo, de que cuando ustedes comparan con la ecografía con la tomografía computarizada, hay una dispersión de la data que es importante y en algunos casos hay un sesgo, ven ustedes, que tiende a subestimar el área. Y utilizando eco transesofágico, el sesgo es mucho menor, pero fíjense ustedes, la dispersión de la data es bastante importante. Esto ha llevado al abandono en la mayor parte de las instituciones del eco como la regla de oro para la medición del anillo aórtico, para la escogencia del tamaño de la válvula, dada la discrepancia con otras medidas. Este es otro trabajo, ven ustedes el mensaje siendo el mismo, aunque el sesgo puede ser que sea poco, la dispersión de la data es demasiado amplia para permitir utilizar esta técnica como el gold estándar. Y fíjense ustedes en este caso utilizando eco tridimensional. Esto ha llevado entonces al uso rutinario de esta tecnología de la tomografía computarizada. ¿Cuáles son las ventajas que tiene la tomografía sobre el eco? La resolución espacial es excelente, puede ser incluso inferior a 1 milímetro. Siempre que hacemos una tomografía computarizada, recogemos una data tridimensional, o sea que se puede modificar y manipular la imagen en múltiples planos, al igual que la ecografía tridimensional. Es el gold estándar para la visualización de la distribución de las calcificaciones. Podemos visualizar el origen y trayecto de las arterias coronarias, la relación de la válvula aórtica o del corazón con otras estructuras subyacentes, y podemos también predecir cuál será el plano fluoroscópico que nos va a permitir ver la válvula perpendicular y ahorrar tiempo al hemodinamista en buscar los planos adecuados. Y esto puede hacerse, obviamente, antes del procedimiento. Tiene algunas desventajas, por supuesto. Una es que necesitamos contraste si queremos ver y medir el anillo. Y hay personas, obviamente, que tienen anafilaxis o que tienen función renal limítrofe, y que esto puede llevar a la insuficiencia renal severa. Radiación, aunque esto es de menos importancia en pacientes ancianos, pero si vamos a ir bajando la edad en que este procedimiento se usa, la radiación puede en algún momento tener alguna importancia. No es perfecta, también hay artefactos. Si tienen estructuras metálicas como marcapaso o algunas otras estructuras, puede intervenir o tener interferencia con las imágenes. Y obviamente los casos de obesidad extrema, primero, que a veces no caben en el aparato. En segundo lugar, atenúan los rayos X pasando sobre el cuerpo y puede crear imágenes de calidad limitada, ¿no? Al igual que el ultrasonido, aunque obviamente los extremos son un poco diferentes. En el TAVI, obviamente, como les decía, el uso ahora es rutinario. Se puede utilizar la tomografía sin contraste para ver la severidad de la calcificación y correlacionarlo con la severidad de la estenosis en aquellos casos donde el eco no nos da una respuesta clara. Pero el uso fundamental, como decía antes, es para planear el procedimiento. Es el gold estándar para medir el tamaño y la forma del anillo aórtico y escoger la prótesis aórtica. Cuál es la relación entre el anillo y las valvas con las arterias coronarias. Y esto es muy importante, como les decía antes, el calibre de las arterias pélvicas. Acuérdense que la inmensa mayoría de estos procedimientos intenta hacerse por vía femoral, y está claro que la mortalidad es muy inferior si se hace por vía femoral que si se hace por cualquier otra vía, transapical, transtorácica, subclavia, ¿no? Una vez que abandonamos las arterias femorales, las complicaciones y la mortalidad aumenta. Y obviamente los hallazgos extravasculares, como son en algunos casos cáncer no diagnosticado de pulmón o disecciones aórticas o aneurismas aórticos que deben ser tratados en ese caso quirúrgicamente. Unas breves palabras acerca del score de calcio. Esta es obviamente una técnica que se utiliza rutinariamente para las arterias coronarias, pero que se ha extrapolado para el uso de la variación de la estenosis aórtica. Y lo que hace es, nosotros tenemos una área de interés, en este caso las válvulas aórticas, y la computadora automáticamente asigna un valor, dependiendo de la densidad de calcio, y lo multiplica por el área, y nos da un score total. Esto lo hace de nuevo la computadora automáticamente, y esto nos da un número que está correlacionado directamente con la cantidad de calcio. Ha habido varios trabajos y este trabajo resume en forma muy bonita lo que se sabe. Ven ustedes que la cantidad de calcificación se correlaciona muy bien con la velocidad del jet de estenosis aórtica. Entre más calcio, mayores velocidades. Y algunos parámetros y algunos umbrales que se han publicado, tanto para mujeres como para hombres, que se correlacionan con la severidad de la estenosis aórtica. Y ven ustedes aquí el área bajo la curva, que es excelente, ¿no? Estos son valores inferiores en la mujer que en el hombre por el tamaño de la válvula en muchos casos. Y el otro punto que tiene la calcificación es el valor pronóstico. Ven ustedes aquellos pacientes que tienen mayor calcificación, tienen un pronóstico peor si no son intervenidos. Esta data similar, y me gusta en la forma como esto fue publicado para mujeres y para hombres, donde ponen la data, cuál es el óptimo, cuál es el más específico y el más sensible. Ven ustedes, dependiendo de lo que ustedes quieran, ¿no? Si quieren un test muy sensible, muy específico, los diferentes umbrales varían, ¿no? Ven ustedes aquí también que para el hombre los valores son significativamente mayores, ¿no? Y esto se utiliza ahora en muchos laboratorios en pacientes con datos ecografíacos no claros. Ya las guías europeas han puesto que se puede utilizar en estas condiciones el uso del calcio en la válvula coronaria. Pero no es perfecto. Algunos pacientes, fíjense en un ejemplo que les pongo acá, una paciente de 83 años y sin embargo, aunque tiene estenosis aórtica de moderada a severa, no tiene una molécula de calcio. Entonces es muy bueno, pero no es perfecto y obviamente tienen que tomar ustedes en cuenta los datos ecocardiográficos y otros datos clínicos y no descartar la presencia de estenosis aórtica solo porque no hay calcio. Pero esto obviamente es un caso extremo. ¿Cómo hacemos la medición del anillo aórtico, el tracto de salida, utilizando la tomografía computarizada? Y es el caso de lo que llamamos las dobles oblicuas, donde la idea es visualizar el tracto de salida durante la fase máxima de apertura en sístole y poner un plano por debajo de las válvulas, y de manera que estos dos planos son ortogonales y nos permite entonces cortar perfectamente el tracto de salida. Y luego, al igual que lo mencionaba, esto se hace ya sea manual o automáticamente. Este ejemplo que le pone se hace automático, sencillamente ponen una zona de interés y mide el área, el perímetro y los diámetros en forma automática. Y de nuevo, esto se considera el patrón dorado para este tipo de mediciones, y de ahí el intervencionista escoge el tamaño de su válvula. Este es otro ejemplo muy similar, donde ven ustedes la anatomía un poco diferente, más ovalada. Aquí hay calcio en el tracto de salida, y son datos importantes de recoger en esos casos, ¿no? Pueden también ver ustedes aquí, si hacen lo que llaman un 4D o de 4 dimensiones, donde las diferentes fases del CT se ponen juntas y se puede hacer un cine, como ven ustedes. Y este cine se puede parar en sístole y hacer planimetría de la válvula aórtica, y ven ustedes la distribución del calcio, y esto se puede corroborar entonces con la ecocardiografía y otros datos para severidad de la estenosis aórtica. En algunos casos, y este es un ejemplo fresco de hoy, ven ustedes que es una válvula aórtica en eco de un paciente con una ventana no muy buena, difícil de ver la anatomía, y la tomografía computarizada claramente muestra que esta es una válvula bicúspide, calcificada con asimetría de las válvulas. No les muestro aquí porque habría que bajar un poco los planos. Este es un rafé que está también calcificado, y es la fusión de estas válvulas derecha y la izquierda. en un paciente donde la ecografía, esta de superficie obviamente, realmente no definió bien cuál era el tipo de patología, y en algunos casos la tomografía nos puede ayudar para ese tipo de definición y diagnóstico. Nosotros y otros grupos obviamente han publicado extensamente, y la precisión de la medición del anillo se ha correlacionado con la incidencia menor de fuga paravalvular, que ahora es significativamente inferior o menor que en las etapas iniciales cuando se utilizaba el eco para la escogencia de la válvula. Este es otro dato donde ven ustedes que dependiendo del tipo de medición que se hace, pueden mejorar entonces o reducir la presencia de fuga paravalvular. Pero realmente no solamente el anillo, la medición del anillo para utilizar una tomografía, sino obviamente estos son estudios muy completos. No les he mencionado cómo se adquieren, pero se adquiere un plano inicial para 4D del corazón, y luego se hace una tomografía computarizada del cuello hasta la pelvis para ver el resto de la aorta, ¿no? Otro uso que tiene es para ver la altura del seno coronariano, ya sea absoluta o relativa, dependiendo de la longitud de las valvas, y les voy a mostrar un ejemplo para ello. Y la distribución y severidad del calcio del anillo, que les decía antes que ha sido asociada con la ruptura del anillo como complicación de este procedimiento. Aquí ven ustedes un paciente con calcificación de la cortina mitroaórtica. Lo ven ustedes acá, aunque en el eje corto no parece mucho. Una vez reconstruido este eje largo, ven ustedes que no solamente es la válvula, sino cómo se extiende en la cortina mitroaórtica. Y esto de nuevo ha sido correlacionado con ruptura del anillo al expander la válvula, sobre todo si se sobreexpande en algunos casos, ¿no? Y esto es importante de ver y de tenerlo en cuenta. La clasificación varía de nada a leve, a moderada, a severa. Fíjense usted aquí cómo se extiende bastante, 1.8 centímetros en la válvula mitral, y de nuevo cada uno de estos tiene un riesgo aumentado de complicaciones, ¿no? Le decía también que la tomografía nos permite ver muy bien la altura de las coronarias. Ven aquí una coronaria derecha y permite medir desde el anillo hasta el origen, y la coronaria izquierda desde el anillo hasta el origen. También podemos medir la longitud del anillo, y la relación es importante. No hay realmente un número fijo, pero yo creo que estas coronarias cuando están más de 12 milímetros, 14 milímetros por encima del anillo son en general seguras de poner estas válvulas. Sin embargo, este es un ejemplo. Ven ustedes, la coronaria derecha está más o menos a 15 milímetros del anillo. Sin embargo, cuando ustedes miden la valva, mide también 15 milímetros. Y usted puede imaginar que si yo pongo una válvula de estas protésicas que desplaza la valva, la coronaria derecha, puede ocluir la coronaria derecha, ya sea parcial o totalmente. Entonces, de nuevo, no solamente la altura, sino cuán largos son las hojuelas de la válvula aórtica, que entonces nos van a hablar de la posibilidad de complicación. Y ahora hay técnicas, obviamente, que pueden cortar o perforar estas valvas y introducir un mayor éxito en estos procedimientos. También se usa de rutina la anatomía de los vasos de la pelvis, y ven ustedes ejes cortos y ejes largos de la pelvis, y realmente se miden a varios niveles de las ilíacas externas y la femoral común. Y de nuevo, este es un dato que se pone en el reporte para ellos ver si esto es posible. Realmente con los nuevos equipos es difícil que eso sea un problema, ya que ahora pueden hacer las arterias relativamente pequeñas de 9 milímetros, carotales incluso de 8 milímetros. Pero hemos tenido casos, obviamente, de obstrucción total de una de las ilíacas, y estos pacientes obviamente son muy complicados para este tipo de procedimiento. Cuando hacen este tipo de CT de 4 dimensiones, permite una visualización excelente del ventrículo izquierdo. También ven ustedes la válvula mitral con algo de calcio, función ventricular normal, pueden medir muy bien la hipertrofia. Y si la tomografía está bien hecha, esto lo hace la computadora en forma automática y bastante bien. Y les calcula fracción de eyección, gasto cardíaco, etcétera, etcétera, en forma relativamente precisa, ¿no? En algunos casos pueden ver como este caso que tiene cierto movimiento sistólico anterior de las cuerdas, pero hemos tenido casos donde la tomografía, en casos de eco ligeramente limitado, nos ha mostrado SAM de la válvula mitral. Hay papel para otras modalidades. Les mencionaba que la resonancia magnética tiene un papel limitado. Nosotros en nuestro hospital la utilizamos cuando el paciente no se le puede hacer una tomografía con contraste o tiene algunos problemas para el eco transesofágico, y se utiliza entonces sin contraste una resonancia para ver el tamaño del anillo, que es también tan bueno como hacerlo por tomografía computarizada. Y esto, desde el punto de vista del pronóstico de la fibrosis miocárdica, hay bastantes estudios en este aspecto que ha mostrado que en aquellos pacientes con estenosis aórtica severa, ya sea asintomática, si tienen fibrosis miocárdica, es posible que el pronóstico no sea muy bueno, y algunos autores han sugerido que tal vez la presencia de fibrosis miocárdica, aún en pacientes asintomáticos, debería ser un elemento que nos lleve a intervenir en estos pacientes. Y finalmente, y en forma periférica, el uso de medicina nuclear, ya no tanto para el diagnóstico de la severidad de estenosis aórtica, sino para el diagnóstico de amiloidosis cardíaca en aquellos pacientes que tienen estenosis aórtica severa, pero tienen bajo gasto o baja función sistólica ventricular. Se sabe que, y los números cambian, depende del autor, pero entre el 8 y el 12%, 14% de los pacientes con estenosis aórtica severa, ancianos, pueden tener amiloidosis cardíaca. ¿Qué hacen estos pacientes? Todavía no se sabe, pero en algunos casos, cuando la amiloidosis es severa, es posible que el tratamiento de la válvula no sea indicado. Definitivamente no el tratamiento quirúrgico. Y ahora que tenemos medicamentos para tratar la amiloidosis, es probable que eso sea un área que se explore en el futuro, y que tal vez la combinación de TAVI o TAVR con medicamentos para el tratamiento de amiloidosis pueda mejorar el pronóstico de estos pacientes. Para concluir, y espero que no me haya pasado muchísimo el tiempo, el uso integrado de varias modalidades es rutinario e indispensable en los pacientes que estamos considerando para tratamiento percutáneo o transcatéter de su válvula aórtica. Las modalidades más importantes son el eco y la tomografía computarizada, y el conocimiento y la integración de estas dos modalidades hace que estos procedimientos en la actualidad sean bastante seguros, y que las complicaciones que eran frecuentes en la experiencia inicial ahora son cada vez más bajas, y por ello es un procedimiento que se utilizará en el futuro en pacientes con bajo riesgo quirúrgico. Y muchas gracias.
Now we'll have some questions for the faculties. For Dr. Manivanan, I have a question. What is your opinion about the pulmonary echo complementary to stress in the assessment of the severity of mitral regurgitation?
Give me 1 minute.
Okay.
You can hear me now?
Yeah.
And you can see me?
Yeah.
Okay. So what is the role of pulmonary vein or pulmonary pressure?
Pulmonary echo, pulmonary lung, complementary to stress in the assessment of severity of mitral regurgitation.
Increase in pulmonary pressure during exercise?
Yes,
No, I think it's pulmonary edema. Pulmonary edema.
Lung ultrasound. Lung ultrasound.
Yes.
No.
Oh.
I think the question about the pulmonary pressure.
So the question is a lung ultrasound in mitral regurgitation. Is that the question?
Yeah.
Yes. So lung ultrasound, oh, sure. I mean, if there is pulmonary edema, then I guess if there is no other reason, then mitral regurgitation explains it. I'm not sure we are routinely doing lung edema imaging in mitral regurgitation. I think if somebody has lung edema, I would suspect pulmonary edema from mitral regurg. That's clinically obvious, I would think. I'm not sure we need lung imaging on top of it. I'm not sure the context of the question, but that is my best answer.
The next question is, which method do you recommend for the assessment of left ventricular function in severe mitral regurgitation? Left ventricular ejection fraction or strain?
I don't know. I don't know. Somebody is smart enough to know the answer, I would love to hear, but I don't know the answer. Let me say this, the guidelines talk about ejection fraction cutoff, which is based on a consensus. It's really not based on what we do. We know an ejection fraction of 55 or even 60% in severe MR is not necessarily normal. But the guidelines use that kind of cutoff because that's based on published literature. Strain is an evolving index, but there is a huge problem with strain and mitral regurgitation. We are looking for a number above normal that tells us there is occult LV dysfunction. This is not like reduced strain relative to what we know is the normal cutoff. So let's say the normal cutoff we use is 20% for the sake of discussion. We are not looking for 19%. 19% is too late in severe MR. What we are looking for, then we may as well use ejection fraction. I suspect what we're looking for, because the preload is increased so much in severe MR, what is the appropriate increase in, for example, GLS? In severe MR with compensated GLS, I suspect the compensated GLS by definition would mean something like 28%. I'm making this up, I don't know. Nobody has this data. So is 25% normal in severe MR? I do not know the answer, but that's the kind of number we are looking for, well above 20%, but still reflecting occult LV dysfunction for the amount of preload. It's a very difficult index to find. It's not easy, but I suspect over the next few years, a few of us will look at it and come up with some cutoffs. We'll see. Neither of these indices are ready for, EF is imperfect, but strain is not there yet.
Thank you, Dr. Manivannan. I have a question for Dr. Sharik. What is the value of transillumination in the assessment of mitral valve procedures?
So transillumination is a relatively new technique in imaging. Transillumination has been used by anatomists for centuries, essentially placing a source of light behind the anatomic structure on autopsy, and has been done to assess the thickness of interstitial septum or thickness of mitral valve. And now there is a technology of transillumination from Philips, and to the best of my knowledge, that's the only commercially available transillumination technology. And it's a useful in a 3D imaging. It's easier to sometimes see the structure, let's say a flail or prolapse as well. But at the same time, transillumination can allow us to tell the thickness of the valve. For instance, in rheumatic mitral stenosis, you can exceptionally thick leaflets. You can also see it in myxomatous degeneration, let's say both leaflet thickness as opposed to fibroelastic deficiency when only one segment could be done. This is an evolving technology. It's only recently became available, and practically it's only available on TE imaging. There are some possibility of using transthoracic imaging, but it's a new way of looking at it. But it's one tool that it's added on, but it has not much validation yet.
Okay. I want to add that there is really no transillumination. This is maybe a little bit of a trick of how you present the images, and you can change in Philips, as I was mentioned, the point of light, but really that doesn't go through the leaflet. No, it's a little bit of a trick in order to present the images in a different way, and it's true in some way facilitates the eye how a structure is visualized. But
really the transillumination is if you put the source of light behind the valve. The whole technology is called the true view, but the part of that is transillumination, and a couple of papers have been published, and just another paper is going to be published in JACE, and it's using the term transillumination.
There is no light involved.
Next question for Dr. Sharik. Do you have some experience in mitral valve procedure during pregnancy?
We have not done any of these procedures other than the only mitral valve procedure would be severe rheumatic mitral stenosis and balloon valvuloplasty. That would be the only that would be in the prep, but none of these would be done in These are all for the most part, elective procedures. It would be rare to have for mitral regurgitation that we would do it. The only that we have done would be rheumatic mitral stenosis, balloon valvuloplasty.
Thank you. For Dr. Leonardo Rodríguez, de la audiencia, la distribución del calcio en la tomografía es útil para predecir leak post-implante, la TAVI.
¿Predecir qué, perdón?
Leak, o sea, fuga
Sí.
para valvular.
Sí, en cierta forma sí, pero creo que lo más importante es para predecir complicaciones. Pero es cierto que si el anillo está muy calcificado y sobre todo si en forma irregular, los depósitos de calcio obviamente no permite la expansión simétrica de la válvula y lleva a mayor fuga paravalvular. Pero son estos casos donde el intervencionista pone un balón un poquito más grande y sobreexpande la válvula, y en estos casos puede fracturar el calcio y romper el anillo. Así que está relacionado con ambos casos, ¿no? Con la fuga paravalvular, que ahora es bastante poco frecuente tenerlas severas, y con la ruptura del anillo, que es más complicada, ¿no?
Otra pregunta, ¿existe algún hallazgo ecocardiográfico o de tomografía que podríamos considerar en un procedimiento de valve-in-valve para predecir riesgo de implante de marcapaso?
Bueno, no estoy seguro para valve-in-valve, ¿no? Sabemos que en la válvula nativa, si se pone una válvula expandible con balón, la Edwards, 1 milímetro por encima del anillo, la incidencia de bloqueo AV completo disminuye en forma dramática. Ahora, en válvulas de valve-in-valve, no estoy seguro que haya data que así lo mencione, pero obviamente entre más alto y más lejos estemos del anillo y del septum interventricular, no sería la incidencia de estos procedimientos. Obviamente, incluso creo que para las válvulas autoexpandibles, de las cuales no tengo mucha experiencia, si se ponen un poco más altas, puede disminuir también la incidencia de bloqueo AV completo.
Thank you very much for excellent presentations. It was really very nice for us. Also, I want to thank Accessofarm because all the time they were helping us. I don't know if Dr. Piñeiro wants to talk something, or Dr. Alexanderson, please.
Bueno, voy a hablar en español, porque hablamos todos español. Bueno, quiero agradecerles mucho. Ha sido un placer, aparte, más allá del contenido académico, creo que en un momento que realmente es difícil para todos nosotros convivir con la pandemia, el reunirnos para hablar de medicina, me enorgullece como parte de este grupo que somos los médicos, que cada uno desde su lugar está haciendo lo mejor para esto, y creo que es importante mantener esta inquietud académica más allá del COVID. Muchas gracias, y gracias, Eric, por organizar esto. Me parece que es muy importante.
Gracias por la invitación, and thank you the other professors for the excellent talks.
Muchas gracias. Solo quería agradecer a todos los profesores y invitarlos para reunirse con nosotros el próximo jueves, que termina ya nuestro webinar. Todo el mes hemos estado trabajando, así que el jueves cerramos ya el curso, y agradecemos a todos nuestros profesores y a todos los asistentes a estas sesiones por el éxito que han tenido. Muchas gracias. Buena tarde a todos.
Gracias.
Un abrazo, Daniel. Chao. Chao.
Doctor Manu Annan, gracias.
Chao a todos.
Sarik, gracias, Leonardo.
Gracias.
Chao, chao.
Chao.
Bueno,
Chao. Thank you very much.
bye.
Bye.